Good afternoon, everyone. It's a Herculean task to really talk in the last lecture that you have to go home on a Sunday. So I'll try to make it quick and try to finish fast. So I thought that we'll cover things step by step as we are taught medicines, the meaning of each word. So before we really go into the depths of the topic, to start off by what is transplant basically? I think transplant is like a marriage. It's a boon to many, whereas it's a curse to a few. So transplant is not always, rosy life is going on. Transplant can be dangerous also. It can be life-threatening and life-taking also, especially if you get dangerous infection. And what is an infection? CDC defines infection as an illness, and it's caused by germs that enter the body and they start multiplying, and they are residing in your body like their own house, and they start eating you off. That's an infection for you. And infection has many manifestations. But for today's topic, we will stick to the point of organ dysfunction. This is graft dysfunction which has been brought into me. What is a renal allograft dysfunction? The definitions are very important. It's basically increase in serum creatinine or a proteinuria more than 1 gram in 24 hours. Why the serum creatinine point I brought here is because the usual graft rejection is a rise of creatinine of more than 0.2 milligram per deciliter. Unlike the routine AKI, which we all are aware of, it is a rise of more than 0.3, or a rise of 25% of the baseline is known as a graft dysfunction. So we have to be very careful regarding the serum creatinine assessment, its understanding, and its management. So graft dysfunction, we have very low threshold. And now comes to the art of transplant. See, this is the life of a nephrologist. That you have to travel a very, very narrow and fight between infection and rejection. So balancing these things is not really easy. Nephrologist looks maybe, Kashmikas are always casual like this, but it's a challenge. You have to manage infection one side, rejection one side, and the complex immunology, which has been taught to us right from MBBS, second year, and just going on and evolving, and we have to be up to date. We will not go to the depth of the immunology from another class. Infection has many implications. It's the second most common cause of death in a transplant patient, first being cardiovascular, and a successful transplant is lost. An opportunity was lost just because the infection got it down. And the impact of rejection is heavy. There are two types of rejection. First is T-cell mediated rejection. There you can see a neutrophil sitting inside a tubule. That's tubulitis for you. And if you treat rejection, you have increased risk of infection because you treat with steroids, a high dose of methylprednisolone. And second thing is antibody mediated rejection. There you have glomerulitis, a neutrophil sitting inside the glomerular basement membrane. And if you treat it still, your graft life goes down for 3 years, and again you have increased risk of infections. So we'll try to focus it on that. And before we really go into the details of infections and all, just want to know the trail of how transplant has evolved right from 24th December 1954 when the first transplant happened to 2nd February 1971 when Dr. K.V. Johnny, he was a nephrologist who I served him for some time. He was the first guy who did the first transplant in CMC without 2nd February. And those days it would be better. Those days there were very few drugs. Used to give Alzaram and steroid sleep. Success or fail, we really don't know. But now the rejections has come down significantly. With that has come up the infections. These infections are really creating a havoc in the transplant sector. So we'll try to focus the topic infection and graft dysfunction. There are 3 ways to look at it. First is infection, which can cause a graft dysfunction. Second is graft dysfunction, if treated, can increase the risk of infection. And the last is infection and graft dysfunction coming together. So we'll try to assess it one by one. Now, before everything happens, KDIGO, which is our main society of nephrologists, which tells us you don't go for really treating infections, try to prevent it first. And they tell prevention is better than cure. So we screen all dialysis patients for some infections residing in them. We try to vaccinate them before transplant, and we give them antibiotics very operatively. We give them prophylaxis, and we'll discuss those things one by one in each of the slides. So vaccinations pre-transplant, definitely Mithil has explained. Basically, in practice, we give 3 vaccines. We vaccinate against hepatitis B, pneumococcal vaccines, and varicella infections. Hepatitis B vaccination, we really give a double dose because the inherent immunity is low and seroconversion chances are a bit less. And vaccinations post-transplant are also very crucial. Don't buy out all those things. Remember one thing, post-transplant, no live vaccine. thymoglobulin, and another was nemolizumab. In the early days, we have seen that you give one dose, all cells go down, infection comes in, patient also goes down. So the nemolizumab is out of the book now. We really use thymoglobulin for high-risk transplant. For a routine transplant, we give induction with basiliximab, which is a non-depleting, and we have methylprednisolone also. And the maintenance immunosuppression. This is very crucial to make the graft survive in a foreign environment which is hostile to the graft. So the standard immunosuppression is tacrolimus, mycophenolate, and prednisolone. And always when we manage a transplant patient, something which stays behind our mind is the net state of immunosuppression, because that transplant patient can be a lupus nephritis girl who ended up in having a stage 5D and transplanted. She was given cyclophosphamide before, she was given rituximab before, she was on steroids before, and now she has got a transplant. So net state of immunosuppression being high predisposes the patient for a little bit much more high risk of infections. And definitely, since they are using long-term steroids, the integrity of their body basement membrane goes down slightly. And prophylaxis. This is a drug, trimethoprim sulfamethoxazole. Initially, it came as Bactrim. It was used right and left by me years back. And nowadays, physicians hardly use it. Probably PTs have never even seen this drug called Bactrim. But nephrologists, it's very sacred for us, like this mummy. It's gold for us. And we give it as a prophylaxis to almost every transplant patient. It prevents a lot of infections, and most importantly, it prevents UTI. This was a drug which was supposed to be given as a first-line agent for UTI, which now nobody uses. Probably only nephrologists. It went out of production also. So, various people have made their own drugs, and we use Selvin DS. Probably you should remember the brand because not available in pharmacies also nowadays. And a little bit into infections. The infections fall into a certain timetable. It's not like, today I got some infection. There are some timetables where you have a certain risk of infection, especially the first month post-transplant when the immunosuppression is heavy and you have been in a hospital for 8 to 10 days. There is high chance of getting a nosocomial infection and Candida infection because you were in OT, you were immunosuppressed heavily, ACs were there. Any infections can come, and always don't forget donor-derived infection. It's quite rare when you have a live donor, but when you are into a high volume center where you do cadaver transplants like CMC or NIMS, there is a high chance of getting a HIV, HCV patient. As far as you need to always check in 14 days. You may get that kidney and you may transplant, and the recipient may get HIV or HCV infection, or malaria also may be hiding inside the kidney, which comes inside the recipient. So donor-derived infections are very important in the first month of post-transplant. And first month, always think of sites. So that's how we physicians are trained. Look at the sites. The common sites is urinary tract. Folies was there, instrumentation was done, digestant has gone, kidney has come into place. So the high chance of UTI, roughly 60% can get them in the first month post-transplant, and you have a high risk of respiratory infection. You were in an ICU, intubated for some time, and that's a higher chance. Certain infections are also very common because post-transplant you have roughly 30 to 35 sutures. So those healing, and most commonly patients who are transplanted are diabetics who are having a poor wound healing. So probably you need to look at surgical site infections, vascular accesses because they are a fistula, and other infections also can come in the first month of post-transplant. In the first to 6 months of transplant, this is the actual honeymoon period for any infection. It can just come in and it can just grow in your body like anything. And we classify infections into these 4 categories what CDC has classified them. The first being bacterial, and you have a lot of infections over there. Nocardia can mimic tuberculosis, and you have viral infections like CMV, BK virus, and you have fungal infections like Aspergillus, Cryptococcus, or Mucor. Mucor, everyone knows nowadays of COVID, black fungus. So these things we have been seeing since the age of the transplant industry, and you can get parasitic infections also quite common in the first 6 months. So we need to be very careful in the first 6 months. So we tell all transplant patients, first month is the most riskiest for rejection and infection. 6 months, if you cross, the risk comes down to a significant extent that it's same as general population. So because by this time the immunosuppression has come down to a minimal level and the risk of infection is equal. But however, there is always a risk of an opportunistic infection because there are 3 drugs. First is tacrolimus, mycophenolate, and prednisolone. So now we go to our viewpoints where we thought about how infection can cause a graft dysfunction, and just for the PDs, any dysfunction, be it graft, kidney, native kidney, you always think of 3 things. This classification has withstood the test of time right from Richard Brady 4 confirmed by immunohistochemistry, which can cause rejection. So, and CMV is a prototype because it can involve any part of the body. It can involve the bone marrow, lungs, GI tract, liver, eyes. It can cause anything. Hence, it is a prototype. It can also cause graft rejection. So, what the clinical tells before it really infects you, please give a prophylaxis. And international guidelines tell you to give 100 grams of valpacetin for the first 100 days or 200 days as per the impact trial. But what the Indian experience, we all are the jugaad guys, does things in an economical way, sufficient for the patient, good for the pocket. So we have come with our own guidelines which aims as authorize that 450 milligram once a day for 3 months is fairly okay. The incidence of CMV goes down almost by 95%. So this is what we follow in India, and we need to look at the GFR also. If the GFR goes less than 45, this drug needs dose modification. And if you got a CMV infection, then you need to really give a full dose. That's 100 milligram morning and evening till you get a PCR negativity. And if not, then give IV gancyclovir. And this is the virus which has been mutating and troubling nephrologists and transplant physicians throughout the globe. Unlike COVID, it's not so fast because the population is very minimal, but you are very likely to get in Hyderabad UL97 gene mutation positive patients. The immune system is facing big time nowadays, and CMV is given an immunity that I won't respond to gancyclovir or gancyclovir. So in this situation, you give pseudocytokine and phosphonate together. And in India, again, 4 or 5 cases are reported which are having UL54 gene mutation, which again gives us an immunity that I won't respond to all these drugs. Then you have a newer drug called letermovir or beribavir, which can kill this CMV. But the key here is, if you have rejection, you don't treat rejection because infection can take your life. Rejection will just take your kidney. So in CMV, you really don't treat rejection, you treat CMV. But you don't reduce the immunosuppression in tacrolimus form, you reduce antimetabolites like mycophenolate, you don't give pulse therapies, you don't do plasmapheresis, you just pray to God that may this graft survive, may the patient survive, that's all. So if you have to trade off, you trade off the kidney, but you don't lose the patient. So the other key point is rejection, which can cause infection. The higher the immunosuppression, the higher the risk of rejection, and you need to watch for those opportunistic infections which are mentioned, bacterial, fungal, viral, and parasitic. And if the patient was treated for antibody-mediated rejection, plasmapheresis was done, they need to look for infections which may happen that was transfused by the blood products or encapsulated bacteria, which are at high risk for these patients. The other point is infection rejection coming together. So again, the prototype here is the BK virus. So this virus was found in a patient whose initial was B and the second name was K, and from there the term comes that it's a BK virus. And this BK virus is there in almost everyone, and once immunosuppressed, it can cause BK virus nephropathy, it can cause urinary structure, it can cause cystitis, it can be hemorrhagic, and it can cause viremia, viruria, and it can be diagnosed by seeing a coffin cast in the urine or by a biopsy. That's how it's confirmed. And this biopsy shows the inclusion bodies in the tubules. That's the BK virus over there. It is confirmed by immunohistochemistry. And you have a tubulitis also. You have a rejection. BK virus with a rejection. What to do? So what the guidelines tell is, if you have rejection and BK virus, don't worry about the virus. It doesn't kill the patient. You treat rejection first, and then you can later on reduce the immunosuppression. So you treat rejection classically with high dose of steroids or plasmapheresis, and in plasmapheresis probably IVIG has antiviral properties also. You can reduce the BK virus thing. And sometimes the situations are tough. You may have rejection, you may have infection, and you may have a PTLD, that is a post-transplant lymphoproliferative disease. This is a cancer. That's just because of immunosuppression. So in this situation, I have my article which I got published IJT around a year back. So in this, we have found a person with a tuberculoma, a person with a lymphoma, and a person who was treated for ATT, and after ATT it caused reduced glycogen cells and got a graft dysfunction also. So it's a hell of a challenge. We need a good team to really analyze and take the patient through. As I have told, it's a difficult balance. Trust me, it's very difficult. So while treating an infection like tuberculosis, which is quite common in our country, we may have to give a very important drug called rifampicin. So if you give rifampicin, you have a high chance that drug levels of tacrolimus may come down. So for PGs, always remember three points in each topic. You have to know the most common causes always. So certain drugs like clarithromycin, you are giving Calimate for LRTI or URTI, you are giving fluconazole. These things can increase the tacrolimus level, and high tacrolimus is nephrotoxic. Again, creatinine may go up. You may get deceived that your kidney is getting damaged. What's going on? Just because the drug is there, increasing levels of tacrolimus. And if you're giving rifampicin or anti-inflammatory drugs like this, that can reduce the level of tacrolimus. And again, your patient may go into a rejection. So we need to be careful. And if you have a transplant patient who is requiring ADT, probably modified ADT will be the way forward. Or give rifampicin. We have transplanted one guy around 8 months back who was on ADT. 8 months after that, we transplanted him. We monitored the rifampicin regularly and successfully he was treated. Make my button use the root. Anyway, the topic is too large and justice to the topic can't be done, especially at this time. Everyone wants to go home. And Sunday is a day, when we Lakshmikants really enjoy with our carbon fiber t-shirts and roam around. So, and this is my boss, Kamal Gil, who is really great. We have done 200 transplants in 2 years, and fortunately, hardly any infections. Whether it's the karma of the boss or the karma of Medicom or it's just God's blessing on Sharad Reddy and Krishna, I really don't know. But whatever transplants has happened, 200, hardly any infections, hardly any rejections. All previous institutes have seen a number of things happening. But here with Kamal Gill, really it's a fantastic time, fantastic, entertaining and learning experience with transplantation. And just because we really pray to the nephrons and everything. Thank you.
Thank you, Shoeb sir, for an interesting talk. I think everyone got a coffee without actually drinking it. So it's open for discussion. Any notes you can always ask.
Thank you.
Such an enthusiastic presentation. I have just one or two doubts. So, you give balance at your prophylaxis when you're giving transport patients. Is that a norm or you do a PMQ monitoring?
But any person who qualified undergo a transplant, we definitely check whether he is COP positive or not. If he is negative, then only he goes into the transplant program. And when we transplant any person, we as an institute, we give thymoglobulin as a induction policy for all, unless they are having certain issues. So once thymoglobulin is given as a depleting induction agent, we give valproxetamol for all, starting on day 5 post-op till day 100.
And your transplantation certificate of this triple immunosuppression for the entire.
Yeah, triple immunosuppression required for the entire.
Nice presentation.
I have one question, sir. As a general medicine and palliative physician, somebody who is heading towards a transplant, what should be my ideal preparation in terms of infection precautions and their work-related life post-transplant? How to prep anybody?
It's a practical question, madam, which we face on a daily basis with patients specifically before transplant. They always ask us, normal torture. So the answer is basically, if you are having an office job, then probably after 90 days and 3 months, he can resume normal activity because that's when the immunosuppression really comes down to a very, very level. If the person is, like a person who is working in really heavy public places, like the Pujari in Napati, recently we had a big Pujari in a big temple we transplanted. So for them, it's like after 6 months, that's when the opportunistic period infection goes down, the risk of PCP goes down. That's when we tell them to go for the job. And remaining in the house, really there is not for any barriers at all. That's practiced by Kamal Giran in a very sensible manner. Here I have seen that we also don't really mask over the patient. And certain to say normal ho gaya. And purely one I'll say from now you are normal. This is counseling and probably so probably barrier with family members and that's not required at all. And it's supposed to be a reverse sort of isolation. Person who is sick should not go over there, probably that's all. So family has to be sensible enough. And fruits which they eat, that should be peeled off. It should not be with the skin, because with the huge modified, which fertilizers and pesticides which are used, we don't know what's coming in there. And food should be freshly cooked, home food. And only in our transplant ICU, Mata sir is allowed home food to come. Otherwise, all patients get hospital food. But Kavamikran micromanage that part also. That patient from day one gets home food. So I think he should feel normal. And job after 3 months definitely should join.
No need of like PMD type of isolations.
Nothing. But PMD is. These isolations are in the guidelines, but last so many months which I have seen here, and these 200 transplants, no infections, probably we need to get our own guidelines. Which AX has come with 450 milligram of valganciclovir. We also need to reduce the level of isolation, because hygiene hypothesis is also dangerous. A person who is not exposed to microbes is at the highest for getting a catastrophic
Which we see last year with post-COVID.
Post-COVID, yes.
Something